Hello, everyone. This screencast is a review of some pertinent cardiovascular anatomy. So after completing this screencast, please complete the online quiz. It is worth 10 points, and you may retake it as many times as needed to achieve your 10-point score. Content from this screencast will also appear on exam number 1. So here is the bony thorax. The anterior surface is formed by the sternum and costal cartilage. The lateral surface is formed by the ribs. Posterior surface formed by 12 thoracic vertebrae and the posterior portions of the 12 ribs. Our sternum, also known as the breastbone, consists of 3 components. The manubrium is the widest and thickest portion. The body of the sternum is 2 times as long as the manubrium. The body is thin and can be easily pierced by needles for bone marrow aspirations. The sternal angle, or angle of Louis, is the anterior angle formed by the junction of the manubrium and the body of the sternum. And then, of course, we also have the xiphoid process. The bony thorax covers and protects the major organs of the cardiovascular system, as well as the pulmonary system. It's an attachment for muscles of ventilation. Here is a sternal deformity, pectus excavatum. This is a congenital deformity. The anterior wall of the chest, several ribs, and the sternum grow abnormally. Produces the caved-in or sunken appearance. It's present at birth and progresses during the years of bone growth. Patients have pulmonary complications, shortness of breath due to altered mechanics of respiratory muscles. There are also cardiac complications due to restriction of the heart. So this figure here illustrates surgical access through the sternum. So to access the thoracic cavity, the sternum is split and retracted. This is known as a median sternotomy. Here is a review of the ribs. The first 7 are the quote-unquote true ribs. They connect posteriorly with the vertebral column and anteriorly via the costal cartilages to the sternum. The next 5 are the quote-unquote false ribs. The first 3 have their cartilage attached to the cartilage of the rib above, and the last 2 are the free or floating ribs. So these ribs, we know that they curve forward and downward from their posterior vertebral attachment toward the costal cartilage. And the ribs increase in length from rib 1 to rib 7, and then they start to decrease as they proceed to rib 12. Each rib has a small head and a short neck that articulates with 2 thoracic vertebrae. The shaft of the rib curves from the neck to a sudden sharp bend. That's the angle. Fractures often occur here. Costal groove is located on the lower border of the ribs. This groove houses the intercostal nerves and vessels. Chest tubes and needles are inserted above the ribs to avoid these vessels and nerves. Let's take a look now at a procedure illustrating insertion of the chest tube.
Using a small gauge needle, locally anesthetize the skin and subcutaneous tissue and the periosteum of the underlying rib. If possible, the pleura just past the rib should also be anesthetized. Make a 2 to 3 centimeter transverse incision parallel to the line of the ribs at the predetermined site with the number 11 scalpel. Bluntly dissect the subcutaneous tissue with the scissors or hemostat. Dissect over the top of the underlying rib until the next highest intercostal space is encountered. With the tip of the hemostat, Puncture the parietal pleura while pushing just at the top border of the rib. You must always enter the pleural space over the top of the rib to avoid damaging the neurovascular bundle that lies along the groove at the inferior border of each rib. Be sure to enter the pleura in a controlled fashion to avoid lacerating the lung with the hemostat. Once inside the pleura, spread the hemostat widely and withdraw it while still open to create a sufficient opening in the pleura for the chest tube. Before inserting the chest tube, place your finger into the hole of the pleura. Move your finger around 360 degrees to confirm correct location in the pleural space by feeling the lung and making sure that there are no adhesions or impediments to placing the chest tube. A large chest tube, a number 36 or number 40 French, is used in trauma to allow for the evacuation of blood and clots. Clamp the proximal and distal ends of the tube before insertion. The distal clamp will keep any blood from rushing out before it can be connected to a collection chamber. The proximal clamp will assist in chest tube insertion, but may not always be necessary or helpful. Advance the chest tube into the pleural space to the desired length. All of the drainage holes should be well inside the chest cavity to provide a proper seal and prevent leakage. The chest tube should be positioned posteriorly and aimed superiorly in the chest cavity. This will allow for maximum drainage in the supine position. It may be possible to see fogging of the chest tube with expiration, and it may be possible to listen for improved air movement on the affected side. Connect the end of the tube to an underwater seal apparatus collection chamber.
That's enough of that there. Okay, let's take a look at the heart now and some of the great vessels. The heart, conical, hollow muscular pump enclosed in a pericardium. Size is similar to one's clenched fist. It is positioned center of the chest behind the lower half of the sternum. Largest portion lies to the left of the mid-sternal line. The apex is approximately 9 centimeters to the left in the fifth intercostal space. 3 layers of the heart. The endocardium. This is the endothelium and subendothelial connective tissue. The next layer, the myocardium, consists of cardiac muscle fibers. It is the thickest layer. And the epicardium, or pericardium, the outermost portion. There is an outer parietal section of this and an inner visceral section. There is between that a pericardial space with pericardial fluid. This fluid helps to minimize friction during cardiac contraction. Looking at the myocardial cells in the myocardium, they demonstrate automaticity. This is the ability to contract in the absence of stimuli. Rhythmicity, the ability to contract in a rhythmic manner, and conductivity, the ability to transmit nerve impulses. The myocardial cells categorized into 2 groups, the mechanical cells. These contribute to the mechanical contraction, and the conducive cells. These contribute to electrical conduction. The myocytes, the mechanical cells, these are large cells. They contain a large number of actin and myosin myofilaments. Enables a greater capacity for mechanical shortening needed for pump action. These cells also contain a large number of mitochondria to provide sufficient energy to the heart. The conducting myocardial cells, these are joined by intercalated discs forming a syncytium. The discs have 2 junctions. The desmosomes, they attach one cell to the other, and connexins. These allow the electrical flow to spread from one cell to another. 2 chambers on each side of the heart, the atria and the ventricles. The atria, those are the receiving chambers, and the ventricles are the discharging chambers. All right, so you want to be able to know where a drop of blood flows from the body through the heart to the lungs, and then back to the heart, and then back out to the body. So can you envision that? Can you kind of name everything going from the superior and inferior vena cava? And as they proceed then through the lungs and then out through the aorta? So questions. Can you answer these? Where does poorly oxygenated blood come from? And what terminal vessels bring it to the heart? Where does oxygenated blood come from, and what vessels bring it into the heart? What vessel does oxygenated blood exit the heart from? So they're all illustrated there. Try to see if you can envision it or kind of walk through the steps, kind of close your eyes or turn away from the screen there and just see if you can kind of map that out. The right atrium forms the right border of the heart. It receives blood from the superior vena cava, the inferior vena cava, and the coronary sinus. The coronary sinus, that's a collection of veins joined together to form a large vessel that collects blood from the heart muscle. Coronary sinus empties into the right atrium above the tricuspid valve. Normal diastolic pressure to enable filling ranges from 0 to 8 millimeters of mercury. The right ventricle forms the largest part of the anterior surface of the heart, a small component of the diaphragmatic surface, and most of the inferior border of the heart. It receives blood from the right atrium that is passed through the tricuspid AV valve. It ejects blood into the pulmonary artery via the pulmonic semilunar valve. This figure here shows a artistic representation of the tricuspid valve as well as an actual anatomic picture. What I'd like to draw your attention to are the chordae tendineae and the papillary muscles. So again, looking at the relationship here, the chordae tendineae, these are strong fibrous connections between the valve leaflets and the papillary muscles. These are attached to the leaflets on the ventricular side, and they prevent the cusps from swinging back into the atrial cavity during systole. The papillary muscles, these begin to contract before contraction of the ventricle, tightening the tendinous cords, thus drawing the cusps together. The right ventricle may be considered as two parts. The posterior inferior inflow tract, termed the body, it contains the tricuspid valve, chordae tendineae, the papillary muscles, and the trabeculated myocardium. The anterior-superior outflow tract, infundibulum is another term for it. This is the area which the pulmonary trunk arises from. Pressures within the right ventricle are lower than the left. The diastolic pressure ranges from, again, 0 to 8 millimeters of mercury, and systolic pressures range from 15 to 30 millimeters of mercury. The intraventricular septum, composed of a muscular and membranous part, strong obliquely placed partition between the right and left ventricles. It forms the wall of each ventricle. The left side is thicker than the right. The thicker left makes sense because blood pressure is higher in the left ventricle, so we would need a stronger muscle to pump blood out. Left atrium, it's divided from the right by the interatrial septum. Thicker wall compared with the right atrium to adapt to higher pressures of blood entering from the lungs. Blood enters the posterior portion via the pulmonary veins. Normal filling pressure is between 4 and 12 millimeters of mercury. Blood ejected to the left ventricle via the mitral atrioventricular valve, also known as the bicuspid valve. The left ventricle, the wall is 3 times thicker than the right. Inflow and outflow sections are divided by anterior leaflet of the mitral valve and the common fibrous ridge. The interventricular septum forms the medial wall of the left ventricle and creates a separation between the right and left ventricles. The left ventricle ejects blood through the aortic valve into the aorta. Normal systolic pressures within the left ventricle are 80 to 120 millimeters of mercury. Diastolic pressures are 4 to 12 millimeters of mercury. Wall thickness again of the left ventricle is greatest compared to other chambers, but pathologic thickening can be lethal. There are 4 valves. These are one-way, allow one-way blood flow. The 2 AV valves, the tricuspid on the right and the bicuspid on the left, and 2 semilunar valves that lie between the ventricles, the pulmonic and the aortic. Or I should say they lie between the ventricles and their associated vessels, again, those being the pulmonic and the aortic. Function of the AV valves are to prevent backflow into the atria during ventricular contraction. And the function of the semilunar valves, again, are to prevent backflow into the ventricles. Here is an artistic representation of the different valves of the heart. And so just kind of envision these here. Which side is the tricuspid on? Which side is the mitral or bicuspid on? And of course, can you name which ventricle is associated with the pulmonic and which one's associated with the aortic? All right. We will spend time in class on the cardiac cycle. So we're not going to go into that here. What I do want to spend a little bit of time with, and this will be important for our ECG lectures, are the cardiac conduction system. And we see that illustrated here by the green structure. Okay, here is another view of the intrinsic innervation of the heart. So starting with the SA or sinoatrial node, this is the heart's natural pacemaker. It is located in the upper part of the wall of the right atrium. SA nodes consist of a cluster of cells, P cells or pacemaker cells. These create the impulses that pace the heart. So the SA node cells, they can reach threshold on their own, thus initiating that impulse that leads to contraction of the heart. It is set at 70 to 80 times per minute. Some texts suggest 60 to 90 beats. It can be slowed by innervation from the vagus nerve. Once the impulse is generated at the SA node, it travels and will cause almost simultaneous contraction of the atria. Now, the SA nodes, again, a collection of cells with leaky membranes. The membranes slowly leak sodium and calcium, bringing them to threshold about once per second. The AV node functions to delay conduction of the electrical impulse. This is a 0.04 second delay. The AV node is located in the inferior aspect of the right atrium near the opening of the coronary sinus and above the tricuspid valve. Also in this region, posterior to the AV node, are several parasympathetic autonomic ganglia that serve as receptors for the vagus nerve and cause slowing of the cardiac cycle. Again, the major function of the AV node during each cardiac cycle is to slow down the cardiac impulse to mechanically allow time for the ventricle to fill. If not for the AV node, the atria and the ventricles would contract at the same time. So this will limit the number of signals sent by the AV node. Conducting fibers from the AV node converge to form the bundle of His to carry the impulse into the ventricles. The bundle bifurcates to give rise to the right and left bundle branches. The left ventricle is activated by the left bundle branch. The right ventricle is activated by the right bundle branch. Halfway down the septum, the right and left bundle branches spread into the Purkinje fibers. The Purkinje fibers complete the pathway through the interventricular septum. There are small branches off the Purkinje fibers that become continuous with cardiac muscle fibers. So here's another artistic representation of the bundle of His and Purkinje fibers. Looking at heart circulation, and this is nice to have a general appreciation for because when we talk about coronary artery disease, we're talking about issues related to these structures. So, coronary arteries, these supply blood to the heart tissue. Deliver blood when the heart is in a relaxed state. They become compressed during ventricular contraction. The first two aortic branches, the right and left coronary arteries, arise just beyond the aortic valve. The left coronary artery proceeds to the anterior descending artery and left circumflex artery. These supply most of the left ventricle, left atrium, most of the ventricular septum, and the SA node in about 45% of people. The right coronary artery supplies most of the right ventricle, the AV node, and the SA node in 55% of people. Coronary veins basically run along the same path of the arteries. Most drain into the coronary sinus, which then goes into the right atrium. A small number of veins, the Besian veins, empty into the right and left ventricles. Now, we only highlighted a few named arteries here. Obviously, it gets very complex, and I'm not worried about you knowing that level of detail. Innervation of the heart involves complex balance between intrinsic automaticity and extrinsic nerves. There are structures like the SA and AV node that provide the heart with an inherent ability for spontaneous rhythmic contraction of the cardiac impulse, or I should say rhythmic initiation of the cardiac impulse. The rate of this impulse formation is regulated by the autonomic nervous system. The autonomic nervous system extends influence to the heart via the vagus nerve and the upper thoracic nerves. These nerves form the cardiac plexus. Extensions from the cardiac plexus innervate the SA and AV nodes. So, sympathetic action causes acceleration of the discharge rate of the SA node, an increase in AV nodal conduction, and an increase in the contractile force of both the atria and ventricles. Thus, it accelerates the heart rate. The parasympathetic, via the vagus nerve, we get cardiac slowing and decreased AV nodal conduction, thus decelerates the heart rate. And that is the end of this screencast.